Good afternoon once again, and you're welcome to this third webinar in the Safe Motherhood webinar series. This is the third webinar in a 5-part series on antenatal care. We have had very amazing presentations and speakers for the last 2 webinars. And here we are again with a third webinar. Our topic today is on key health system challenges, barriers, and solutions to improve quality of ANC services. I want to welcome you again, and we have a very wonderful panel of experts from the field in terms of antenatal care and the different health system blocks that we want to look at this afternoon. We'll be looking at a block on leadership and governance. We'll be looking at supply chain, as well as data utilization and anything related to HMIS. I want to remind us that as we start, please make sure your microphone is on mute, and only unmute when you are going to speak or when you have a question and it's time to respond to questions. We'll run up to 4 p.m. and we'll close right at the top of the hour at 4 p.m. I want to welcome Dr. Moses Walakira. Are you online?
Yes, Richard, I'm online. Good afternoon to you.
Good afternoon. Dr. Moses Walakira, you're welcome. Dr. Moses is a program specialist with the UNFPA and also in charge of family planning service provision at UNFPA. Dr. Moses is going to be our moderator for today, and I'll be supporting him in the background. So Dr. Moses, please take over and let's start the webinar.
Yeah, thank you so much, moderator. Good afternoon, ladies and gentlemen. You're welcome to our webinar today. As Richard indicated, today we are going to focus on the key health system challenges, barriers, and solutions to improving the quality of antenatal care. And probably some of you have been part of the last sets of sessions we've just had, and we mainly focused on antenatal care. And we definitely know that antenatal care coverage in Uganda has been a success story for quite some time now. And presently, we definitely know that over 95% of the pregnant women attend antenatal care at least for the first time. So they have at least one ANC contact. And we definitely appreciate that good care during pregnancy is very critical for both the health of the mother and that also that of the developing baby. And that's why we are focusing this month on antenatal care services. And probably there could be some good practices that team members are going to share that we can adapt, that we can put to scale for us to be able to have, to extend especially the challenges related to, to address the challenges related to the continuum of antenatal care. We know that fourth ANC and beyond is still a problem. If you are talking about the 8 visits that are recommended now, definitely we're expecting to have a lot of challenges and linkage along with the continuum. Good ANC, as has been emphasized, links the woman and her family with a formal health system, but also increases the chance of using the skilled attendant at birth. And also from the other discussions we've had, we know that this contributes to the good health through the life cycle. And so if you have inadequate care during this time, you realize that it breaks the critical link in the continuum of care and affects both the mother and the baby. Today's topic has already been highlighted, and this time round we are focusing on the building blocks of the health system. How does the health system affect the ANC service provision in terms of coverage, but also in terms of quality? And as Richard highlighted, we are not going to focus on all the 6 building blocks. We are only going to focus on the 3 key ones and that is leadership and governance. And we shall have Sister Immaculate from Kabale, Mandera, that will be discussing some of the examples of good experiences in Kabale regarding how leadership has been able to influence ANC quality and coverage within the district, but also to improve the overall outcomes for women that are pregnant and then those that come in labor. The second key area that we are going to focus on is definitely the supply chain management system. We very well know that supply chain is very key. And if we are going to focus on antenatal care coverage, but also focus on the quality, the overall quality of the program, then we need to focus on the supply chain for reproductive health commodities. And today we are privileged to have Mr. Martin Oteba, who is a deputy chief of party. And many of us have known him for quite some time in different capacities. He used to be a commissioner at the Ministry of Health in charge of pharmacy. He has been a deputy chief of party for Uganda Health System, Uganda Health Supply Chain Project, and is currently deputy chief of party for the supply chain, for strengthening supply chain systems activity. So he's going to basically talk to us about the reproductive health supply chain and how this influences the quality of antenatal care and what are some of the barriers and solutions that we should be focusing on addressing to ensure universal coverage of antenatal care services. And then the third key area that we are going to focus on today is basically related to data management for ANC. So we are basically going to look at the health information management system for ANC, how it is done, what are the current gaps, but what are the areas that we should improve, especially the last bit, the use element. So that is going to be the focus for today. I think we can launch into, I've taken some bit of time waiting for the other members to join, but I think we have a quorum, we have 41 participants, and I think we can launch into the discussion. So this is to introduce to Sister Immaculate Mandera, the Assistant District Health Officer, MCH for Kabale. She's going to take us through the first session, and this is going to focus on leadership and governance. Richard, can we have the presentation uploaded?
It's coming, just a few minutes.
Yes, and Sister is going to take about 20 minutes of the presentation. And then after presentation, we shall have discussion. If there are specific comments, questions or comments, you can be writing them in the chat as well. But we shall give you an opportunity to raise your hands and also raise some of those specific questions, comments, or any supplements to the presentation. Sister Immaculate, over to you.
Yeah, good afternoon, team. My name is Immaculate Mandera, Assistant DHO Maternal Child Health Kabale. My presentation is on leadership and governance for quality antenatal services at the district, facility, and community levels. Next slide. That is the presentation outline. Next. Kabale district, get off this thing here. Kabale district is located in the southwestern region of Uganda with Ubo's population, I'm not seeing. Yeah, Ubo's estimated population for 2019 at 248,700, estimated pregnant women 229,318, and women of childbearing age by that time were 1,054,866. Children surviving under 1 year were 45,863, and children under 5 years were 940,207. We have a number of facilities which are offering ANC services. These include our regional referral hospital, Kabale, the 2 PNFP hospitals, Rusoroza and Rugarama. We have 4 health center 4s which are government owned, 7 health center 3s, 6 of which government and 1 PNFP, 33 health center 2s, 24 of which are government and 8 PNFP, 1 PFP, and 1 clinic. And the human resources for health, in particular for maternal child health services, the district has filled the position for assistant DHO maternal child health, and that's why we are supervising competently. At facility level, all our health center 4s have registered nursing officer midwife to supervise maternity services. At health center 4 and the lower levels, we have 55 approved vacancies for enrolled midwives, but unfortunately only 29 are filled. We have a gap of 26. At our health center 4s, we have resident medical officers who are able to do for us emergency cesarean sections in case of complications of MCH. At community level, we have good mobilizers, our VHTs, very many are functional, and also our health unit management committees have been oriented on how to assess the facility performance and take back message to the communities on the available services and its utilization by the community. Next slide. This slide shows the Kabale ANC coverage for 2019-20 financial year. The map on the left is showing the facilities, how they performed in the ANC care. And when you look at the red sub-counties of Rubaya, Kamuganguzi, and Kaharu, their coverage for first and fourth ANC are quite low, and those are the sub-counties in this financial year we shall focus on. Already we have started with Chuai projects there. And then those in green, we have Maziba Central Division. These ones are doing well. We shall copy some examples from there to take to the red sub-counties. Next slide. Next. This is our service uptake for the mothers for the last 3 years, 2017-18 financial year to the 2019-20 financial year. The targets you are seeing there are national targets for early ANC, teenage pregnancy, fourth ANC, the LINs, those are the treated mosquito bed nets for mothers at first ANC. Then remove this. Third IPT, iron folic acid at first ANC. So our performance, yes, for 2017-18 financial year, our first ANC was below the national target, but our teenage pregnancy was below that target, which is good for us. Fewer girls are getting pregnant. Then fourth antenatal visit was still below the national coverage. First ANC LINs received were at 87. IPT3 was
Mr. Immaculate, are you there?
projects that we started in these indicators. So our ANC went to 30% because it is an indicator. First trimester ANC was a HUI project. Teenage pregnancy slightly went up, and we couldn't explain that. Fourth ANC went up. It was also a HUI project for that financial year. The liens we were supervising closely and even counting. So take us back to the slide. Yeah, our coverage was 96%, and then IPT sought ups. The upsurge is quite big. This is because this indicator was made an appraisal indicator to all in charges in the district. The midwives and records assistants. Records assistants, because sometimes they don't document accurately. So it was counted on them as well, and the midwives plus the in charges. Folic acid were at 99%, possibly because of some of the stockouts. In 2019-20, we didn't move far in this indicator for ANC, but it remains our HUI project even for the current financial year. Teen pregnancy went down. A lot was done in the field through community dialogues, talking to the young people, even talk shows with the support from our partner. And then fourth visit has gone down to 54%. They remove it. I think this is because of the COVID. In our fourth quarter, when we analyzed our performance, we didn't perform well because of the COVID pandemic. The lean distribution also went down because of the same. The third IPT also went down, and folic acid and iron supplements down, all because of the COVID. But the previous quarters were okay. So the early ANC stagnated, teen pregnancy dropped steadily, and fourth ANC has been fluctuating and slightly dropped in the 2019 financial year. Commodity supply for liens has been adequate, but with the widespread stock out for fancida, iron, and folic acid. This was commonly noticed in the PNFP facilities, but we did a redistribution. Next slide. Next slide. Yeah, this is showing the triple elimination of HIV, syphilis, hepatitis B among pregnant mothers. For the last 3 years, we have been implementing the HIV, syphilis dual testing. The hepatitis B has just been introduced in the guideline. So the reason why you are seeing zeros there, the 4 is for the referral hospital. So our HIV testing coverage has been 94% January to June of 2018, 94% still for July to December, reduced January to June 2019, and it slightly went back to 94% in July to December 2019, then 100% in January to June 2020. The differences could be because our Center 2s are also doing HIV testing, and they are not doing dual testing. Otherwise, the syphilis testing and HIV testing should be all at 100%. But because Center 2s are testing, they don't have the syphilis kit. Only 8 and 3 sites are conducting HB estimation. This has been a very big challenge to the facilities, but for sites which were voucher sites, we encouraged them to buy the HB machine, and even the partner bought, but the lab staff continue breaking them down. District positivity for HIV, syphilis, and hepatitis B stands at 0.9%, 4%, and 0.3%, respectively, for January to June 2020. Enrollment in care of all identified HIV pregnant mothers was at 100%, while treatment of positive cases with syphilis was at 31%, yet 206 were tested positive. We think that somehow there was documentation error. Otherwise, a mother who was identified positive for syphilis, normally all were initiated on treatment, but we shall follow up and find out those facilities which tested positive and yet did not treat if they are there. Next slide. Yeah, this slide shows the logistics and supplies we received for MCH from our partner, USAID Rights Southwest. Normally, we do needs assessment and we are able to communicate the gaps in different areas which may affect the service delivery. And after sharing with them, they accepted to give us this logistics. Next slide. Health information system management. We have already conducted the rollout of revised HMIS tools, and all sites are stocked with the antenatal care tools. All HSD have functional computers and internet access supported by our partner, the USAID Rights. DHIS2 HMIS data entry is decentralized at health sub-district level. The data can be entered at that level, and they bring here hard copies for us to verify what they have entered. Conduct routine data clinic with support from partners. We have done this routinely and regularly, and also we have conducted monthly performance review meetings and data use for decision making at facility level, and also at the district. We analyze to check who is performing poorly, and we give feedback. We conduct regular on-site HMIS mentorships to review use of the new HMIS tools and reporting. Then gaps identified are fixed. Next slide. Roles of leadership and governance to improve quality of antenatal care. We have had regular support supervision by the regional referral hospital to our lower facilities using the C2I approach with the grants from USAID Rights Southwest. They give feedback to our office and we do follow-up. We also conduct regular integrated support supervision as DHT with support from USAID Southwest and also the PHC. Logistics and supply chain monitoring is done regularly to enable us identify facilities with the excess stock, those without the stock, and we do redistribution of commodities to our facilities which need these items in time. MNCH equipment support from USAID Southwest has been achieved through sharing. Routine technical support supervision is given to the district. It's weekly. We have program officers weekly in the district. They work with us. They are part of DHT. Regular support supervision is done also by HSDs to our lower health units. And the HSDs are supervised using the reports they bring to confirm whether they have reached there or not. The MCH section carries out regular needs assessment to identify gaps. Those gaps which can be fixed without any financial support, we handle. But what requires financial support, we make a report to the district leadership and our partner USAID Rights. They always support us. Training of staff in focused antenatal care was discussed following a needs assessment, and this training was conducted in our facilities. We have had a number of mentorship and coaching in focused antenatal care following the training. We use our data to start QI projects in ANC and many other services. For instance, for the last year and this current year running, we realized our first trimester ANC is very low. We talked with our partner and the project officers in the district, and we agreed to do mentorship and QI coaching in the early ANC and the deliveries. So we have done this in all our health center 3s, the 2 hospitals, and the 3 health center 4s. We also promote male partner involvement in MNCH, and this is done by us, the technical people. Also, our district chairperson, Honorable Patrick Besigye Kiwa, is so passionate about male involvement in MCH program, even nutrition programs. So when he's in the facilities, he would ask the women to always come with their husbands who will listen and understand the issues from health facilities and later on support them. District administrative and DHT leaders participated in the RBF assessment. The total number of facilities which were enrolled in the RBF, there is a mistake there. We have 12 facilities, all the health center 3s and the health center 4s. The other facilities are yet to be enrolled, like the 2 hospitals and the regional referral hospital. We also initiated, after carrying out a research, and we realized that people did not understand the benefits of antenatal care. We used this finding to discuss with our partner, USAID Southwest, Right Southwest. There is a need for community dialogues, and they facilitated this program. It helped us to meet the people in the community, including men. They asked their questions, we were able to answer, and at the end of it all, we realized the increase in coverage of not only ANC, but also other MCH areas. Challenges, we have limited the access to ultrasound scan services.
You can plan to finish in the next like 4 or 5 minutes.
Limited availability and access to hepatitis B test kits. It is newly rolled. COVID pandemic affected access to ANC services, and there is erratic supply of HIV syphilis dual test kits in the lower health facilities that are providing ANC services. That is the health center tools. They don't order. We recommend that government through Ministry of Health expands access to ultrasound scan services in line with WHO 2016 ANC guidelines. NMS should include hepatitis B test kits on the essential medicines and supplies list to the districts. NMS should endeavor to supply HIV syphilis dual kit test kits to lower facilities, providing ANC services every cycle. Next slide. We acknowledge the team players. Ministry of Health, our partner, USAID Right Southwest, all the frontline health workers, district leadership, DHT for the technical services, our regional referral hospital for that supervision and technical guide, the HMIS and the village health teams. Thank you for listening.
Yeah, thank you, Sister Immaculate, for the presentation. It has been very comprehensive. And from the presentation, you've clearly highlighted the strong collaboration between the IP, the regional referral hospital, and the district. You've also highlighted the aspect of integrating quality improvement approaches to address gaps, but also you seem to have stronger use of data in the district to guide the routine operations. And there was a component of integrating some of the MCH indicators in the staff performance appraisals. But you have also illustrated the effects of COVID on ANC uptake, but also the fact that sometimes there are erratic supply of some of the RH commodities. Members, at this point, let's It's an opportunity for us to raise questions or any compliments or any comments. I've seen some of them maybe could be in the chat, but you can raise your hand. We have about 6 to 10 minutes for the discussion. Yes, Grace?
Dr. Richard. Thank you, sister. That was a really nice insight into what's happening in the area. Really, I just wanted to get your clarification or guidance from the perspective of the private sector. Could you tell some highlights on your experience and progress in this initiative with the private sector, both commercial, like private health practitioners, and also the PNFPs? Because at times, we're lumped together with PNFPs and PHPs, and then sometimes we're separated. It would be good to highlight for us any progress or experiences or learnings from your engagement with them. Thank you.
Sister Immaculate, there's another question in the chat. With the 12 RBF facilities, is there any impact of RBF, especially on the HB estimation in the district? So that's another question. So members, you can put up your hands or you can put your questions in the chat. Dr. Myers.
Thank you, moderator. I'd like to ask Sister, what incentives has she put forward that made her achieve IPTP uptake of 68%, and yet the national average is well below 42, 43%. So maybe it's a lesson for us to learn from that intervention that has raised the IPTP uptake to 68% for that matter. So let's give us how she has made it so that we can emulate that matter.
Yeah, thank you, Dr. Myers. Sister, maybe you can come in and answer those 3 questions we have so far.
Yes, thank you, Doctor. Let me start with the Myers. For IPTP3, initially when it was introduced, just like other districts in the country, our performance was very low, 8%. So when we analyzed the data from the office, we said, as the district health office, that will be an indicator for my own staff, my own appraisal. CAR will appraise me on that. Then for facilities, all the in-charges will be appraised on this indicator, midwives and the records officers. It worked. When they heard that they are supposed to be appraised on this indicator, all worked hard to make sure that they document accurately, and when they are capturing data in HMIS, they count accurately to transfer the information there. That is how we achieved it. It was an appraisal indicator and also QI project in some of the facilities. Then for the 12 RBF sites, we have had only 1 quarter with the RBF, that is April to June quarter. We received the startup funds, and most of the facilities were guided by the plans they prepared. Buying the HB estimation machine is one of the things we emphasized, and they procured a number of equipment and medicines from joint medical stores. So we are yet to verify this when we go for the supervision of this quarter. We've had interruptions. We are
SLR. Richard, are you there?
Yes.
Richard?
Yes, I am.
I think it has got some challenges with their connection.
Let me try to reach her.
Yeah, and then the question about the private, commercial, and PNFP facilities. We don't have very big problem with these facilities. First of all, we have positive attitude towards them and the services they offer. And when we are having any training in the district, we make sure we pick them because their performance affects our performance as a district. Even when they lack medicines, we ask them to come to the district stores and check if there are medicines they want. And if they are there, they make the they go back, make requisition, and when they come here, they are given from the health office. But we only tell them they must recognize on their stock cards that they picked these medicines from the district health office store, and they should update stock cards. And of course, the medicine which they have been running sort of mainly is a Fansida. Fansida is expensive, so they would get frequent stockouts. And for us, we also do frequent refills for them. That's why our Fansida uptake does not drop down even when theirs is out of stock. We communicate they pick from us. And always during our supervisions, we pick excess medicines we bring to the store. When we are going for supervision, the person in the store goes with the requisition book and all other books that people can use to request medicines. We go with the medicines. When we find you don't have, you request issues and we do the supervision, then we move to another facility like that.
Yeah, sister, you have a series of other questions. Maybe
Yes.
in the next 2-3 minutes, you can try to respond to them. The team wants to know what you are doing as a district to support continuity of MCH services during the pandemic. And then also with a gap of 26 midwives, what you can communicate to the team and what the district is doing to address the gap, but also regarding the impact of data on uptake of ANC, what strategies did you use to achieve the results that you have? And there's a question on supply chain, I think, which are raised.
Again, that third point I've not got.
Regarding the data, the impact of data on the uptake of ANC, what strategies did you use to achieve the results that you have? And there's a question on the supply chain. I think we're going to discuss it. I'll bring it up when we have a session on supply chain. And does the district contribute any additional budgets from the locally raised resources to procure additional supply? Maybe you can first address those.
Okay, thank you, Doctor. On the first one, what are we going to do as district to continue MCH services? MCH service, or whatever service that comes to district, we have learned that it is important to integrate. We don't run vertical programs. The moment we start a program, we integrate in our routine. When we go for support supervision, we keep touching on all areas because we go a team of different backgrounds, and each one reaches the facility, moves to their section. So we continue with or without partner support to do all our works because all of us will be in that joint supervision. Then the gaps of 26 midwives, that is for the enrolled midwives, what is the district doing? We have a plan of recruiting, but you know, we had a number of challenges. Because of the pandemic, they were not advertising. Then eventually people have now gone into campaigns of the NRM flag bearers. We believe when they settle after these campaigns and all those other dust when settles, we shall be able to sit together and plan when to give the vacant positions to the District Service Commission, and then the center will approve according to the wage bill available. Regarding the strategies we have used to achieve our ANC, coverage. First of all, as I was said, we have used the research findings to tackle problems. Where the people are saying we don't have knowledge on this, we went for social mobilization and sensitization using the different cadres, VHTs, the HUMIC, our political leaders. We give them just a brief message in an area. When they're in the communities, they are able to pass that message. Then when they are on the radio for other programs, they are able to communicate something in these areas. And our chairman is so passionate about these health services. He always communicates. Then we still used the strategy to inform all other partners in the district that our main problem can be addressed if we had a community dialogue. A longer time to discuss within them, they bring in their issues, we explain. So we are able to have these coverages improve because we met the people in the community. They talked what they feel is bad with our systems, and we noted, also tried to improve them. And then we ourselves made sure that the health workers are always there at facility. We monitor the presence and the presence of a person at the facility, not only being present, but doing work. That one we did. Then we use data. When we reach a facility, we look at the targets. Every year in July, as we start the financial year, we give targets for all facilities in different indicators which are monitored by Ministry of Health. Then when we are supervising, we actually look at the target set for a particular indicator, what they have achieved so far. And we even help them weekly. If you can break down this target, maybe you are supposed to see 4 children, you are supposed to see 10 antenatal mothers. We break it like that weekly, monthly, quarterly, and then finally midterm and yearly. If you are monitoring yourself like that, we expect you to be able to achieve. And then we start 2I projects where they are poorly performing.
Yeah, thank you, Sister, for the presentation and the responses. There are still quite a number of questions in the chat. I think you can continue responding to those in the chat as we are launching into the second presentation.
Okay.
I think the topic has been very interesting. Thank you so much, and the Kabale team for the commendable work. It has generated a lot of discussion, and definitely that's why there are quite a number of questions and people are interested in knowing exactly what is happening. So you can respond to the other questions in the chat that you have not provided responses to. Members, at this point, thank you so much. At this point, let us launch into the second presentation. And this is going to focus on the supply chain challenges and solutions related to antenatal care commodities. And Mr. Martin Oteba is going to take us through the second session. So over to you, Martin. Richard, did you have the presentation?
Okay, thank you very much. Am I audible?
Yes, loud and clear.
Thank you very much, Dr. Walakira, and thanks.
Can we upload the presentation from this side? Yeah, it's done.
Yeah, and thank you, Richard, for inviting me. I want to quickly say that this came when I was on vacation and I was in my village enjoying my time. So I have to do a quick thing. Well, as introduced, my name is Oteba Martin. I work with the Management Sciences for Health with the Strengthening Supply Chain Systems activity, which is now about 5-6 months since I went. Prior to that, I was working with the Energy Supply Chain. So I was asked to present something on supply chain challenges and solutions to improve quality of antenatal care. And I've got a very, very compressed presentation. If we can go to the next, yes. For the sake of Uganda, I've picked about 3 indicator items that are, in my view, are very applicable to help us look at the ANC in terms of supply chain requirements. And specifically, we've already heard from Sister Mandera on the IPT issues in Kabale as one example. And also we've had issues around test kits, specifically the Hep B, and of course the dual HIV syphilis test kits. And we also put in the ART, access to ART, especially with regards to elimination of mother-to-child transmission. This information is a result of an analysis this morning of what we have in the DHIS2. And specifically, we look at the targets in terms of availability of these commodities at the national level, and also what was the actual performance for last year. So you can see from that for the 3 identified areas, the variations were not great in terms of availability. We achieved significantly at national level stock availability for IPT, but Sister was talking about the shortage of Fansida. And then we also, as for the HIV related, the 90-90-90, and as you can see, for test kits, we stood at 88%, and for ART, and this specifically is for the TLE combination therapy for mothers or expectant mothers who may be HIV positive. On the surface of it, this looks like a wonderful performance. Let's go to the next. What actually is the objective of the supply chain? All objectives can be put in one, maybe we call it a goal here. And that is to ensure that commodity security for all programs achieved for all programs, and that all people who are in need of commodities access them at the highest levels of care. And in this case, when we talk about all the commodities that Sister mentioned, we are supposed to ideally have them, and that every mother, expectant mother who comes, is able to get tested, is able to have the TT when necessary, is able to have the IPT as required, is able to have the antiretrovirals for EMTCT. If nutritional issues are there, the supplements are available, and so would be the hematinics. So the objective is one, the big goal is we just have to ensure commodity security for all programs, including maternal child health programs. Next. For that to happen, there are specific tenets that we must achieve. There are specific tenets, and these tenets are very obvious. We all have, in one way or the other, looked at them. Most of them relate not to facility level activity, but some do indeed. At the national level, as well as the district level, we are talking about planning for commodities. And this planning at national level constitutes part of what we would call the procurement process. So procurement planning is a basic principle that will help us ensure commodity security. And that means, therefore, we have to do careful commodity needs identification. And we should do this based on our different burdens or needs. And then as a part of preparation, we should also carefully define what our expectations in terms of the trend, the trends of delivery of these commodities, what commonly the supply chain people call pipeline. So we need to define the pipeline. So as Sister was talking, I realized there were a few issues. And of course, she did mention that Right Southwest assisted quite a bit, and that there are certain activities that need to be done to improve certain areas. The second issue is efficiency in procurement. From the district perspective, procurement relates to making orders. Procurement relates to making orders by either the district health team or by the individual health facilities. The more we do this efficiently, the better. The more we free also some resources to areas where there is a bit of a challenge. And for efficiency to be recognized, we have to select at national level, solicit competitively the people who will provide these supplies. We have to track, as agreed at the beginning, what will be the delivery schedules of these supplies. And we are talking about realizing these deliveries timely. This is also true for health facilities. If the NMS, if the health facilities make orders to the NMS, these items have to be realized by the health facilities. They have to be received. And both the NMS and the health facilities have a mandate, have equal mandate to demand for certain things to happen. One, the facilities have to demand that we made our orders, deliveries have been made, we have not seen item X, Y, Z. And NMS is obliged to answer those questions or inform the district in advance or health facility in advance that, sorry, you've made these orders, we are unfortunately going we don't have this and we shall not supply, so that the district actually proactively takes action. You are lucky, Kabale, that you have Right Southwest, which can still buy certain things, and as I can see, they are very good at helping you to provide for some tools and instruments that you need at ANC. The next issue is warehousing and storage systems need to be up and running, they need to be appropriate, and they need to be quite efficient in working among themselves. Warehousing relates to, at national level, national medical stores should have stocks that speak to the needs of the health facilities for ANC and any other program. And the facility store or district store, Sister also talked about the district store, should be in a partnership coordinating with the national medical stores to be able to ensure that what they need is what definitely they order for and what they supply and what the expectant mothers are given. But for all this to happen, the other tenet is that the supply chain information systems must be well managed. The logistic management information systems at facility level, at district level, at national level, and national medical store level need to be talking. The data must be there. When there is stock out, document stock out. When there is excess, document those excesses and take actions as required. I have already mentioned ordering systems. The internal ordering systems need to be meticulously managed at all levels. And of course, governance, as governance requires, the leadership of the districts need to be able to be following up with the facilitator in charges, the health sub-district in charges on what's happening. The distribution system, which includes transport and many others, need to be fully optimized, meaning that they need to be working in tandem. They need to be maximally used and achieve the timeliness and the timeliness of delivery, as well as in realizing the pipeline as had been planned before. And this will probably give us a functional health supply chain. Sister talked about human resources. Across board, we have challenges with human resources, but the supply chain human resources are even more threatening to the health system. And these human resources need to be thought about. Often we think when we have reoriented a nurse or a clinical officer to do supply chain work, we think we've solved the problem. But no, this is patching, and most of the time the patches fall off. The supply chain is usually an entire network of actors integrated in one whole. So in the case of Kabale, as I've just heard, there is also the right southwest, there is National Medical Stores, there's Ministry of Health itself, there are other program areas dealing with maternal and child health, others dealing with HIV/AIDS and so on. These, if not handled smartly, themselves are an impedance, they are themselves a barrier in delivering quality ANC services, and specifically in the era of HIV/AIDS. If we have to realize births free of HIV/AIDS, then these systems must be convergent, not divergent. The other big challenge is, of course, commodity financing. And if you saw, I raised the question there, whether or not the districts the district of Kabale does contribute some funding from whatever it collects from the local revenue. And finally, around these tenets is the equity of allocation. We still run a kit system for very critical service delivery areas like Health Center 3s and Health Center 2s. Sister mentioned redistribution. Most of the redistributed products are either the products which are pushed, which include those products from those kits, or others which have also been pushed in one way or the other. If we were doing our allocations more equitably and efficiently, we would be freeing some resources for the very highly required items for ANC care. And because perhaps we have issues around that, we have been unable to leverage from the little resources currently available to the country. Next slide. So in summary, we have not so many drivers for community security. The bottom line is planning, planning, planning. But planning needs the right competences and the right mix of competences in terms of human resources. There is need for commodity financing, and this must be in an equitable manner. And what we do as in terms of determining our priorities must be the center stage. And the stock status then determines whether or not our commodities, the commodities we need are in place. Next. Our current challenges related to supply chain speak to what I've already talked about. The primary one, basically, which also hints and hurts the entire system, is the human resource. Here we are talking about the competences, we're talking about the numbers, we're talking about the roles and responsibilities. Once one is broken, the entire system loses the appeal, loses the confidence and the confidentiality that the clients need, lose the trust, and also loses the meaning of functionality in its sense. You just take an example of a midwife who, instead of giving an antenatal talk where she maybe designs to talk about nutrition and perhaps some social well-being at home. She is also the one who has to also give, to go and pick this particular commodity, the other commodity, administer TT where necessary, provide for IPT, and so on and so on. That compromises the functionality of and the quality of antenatal care provided. So human resource targeted to support the health system with managing of the supply chain is critical. The next bit of it is infrastructure, related to infrastructure. I'm not going to go into the details of the service provision infrastructure that we normally see, but I'm going to basically try to talk about more of the supply chain infrastructure. For example, when you go to many of the health facilities, the small storage space is a junkyard. Is a junkyard for everything, right? Is a junkyard for everything, where you find a bit of a tire here, a bit of what there, a bit of what there. So even the person who has the time to go and pick the medications from there gets, wastes a lot of time trying to unearth. A lot has been done to try to improve on this, but it takes all of us to put a lot of efforts all the time to do that. The other bit is the appropriateness of this infrastructure. Just like you need a good ANC public health site for public health talks, you need the right place to dispense these medications for the people to have a good experience to make reference to and come back that, oh, my sister, I was in such a place and I was taken care of. If you go to where the dispensing is taking place, oh, excellent. If you go, so people are encouraged to come back, not just because there's a nurse or a doctor. No, people also look at the ambience of the environment. The planning bit of it, most of the time, I don't know how much the ANC team or the maternal child health team in a health facility like Health Center 3 and Health Center 2 get involved in planning for commodities in that health center. For example, quantifying for HB, okay, for Hep B, quantifying for the Fancida, quantifying for the test kits, and so on. How much effort is put? How much support does the district give? And how much support, like, for example, does the Ministry of Health also give? In which case, therefore, what is the extent to which we address the needs of the facility and therefore of the district? Data management already was mentioned. If epidemiological data or demographic data is not well managed, the chance that the supply chain data is going to be managed through the logistics management information systems properly is also a challenge. But of course, we are a poor country. Talking about finance to address all these other factors may look like we are joking, but we have to talk about finance as well. We have to talk about adequacy of financing. At the moment, we have more than 50% of our resources for procurement of essential medicines and health supplies being donated, especially for critical elements like HIV/AIDS test kits, HIV/AIDS antiretroviral commodities. For essential medicines, where the government is the only provider, we have less than $100 million. And that is nothing in terms of the requirements of the country. So put together, we need to be more efficient, more equitable. We need to reprioritize our priorities in terms of how do we plan for commodities? Which commodities should we plan for at this point in time? What quantities of these commodities? And what reasons do we give for that prioritization, so that at the end of it all, it's not a repetition of what we got last month, and then we end up saying we need to redistribute, when actually the stock of this particular item doesn't need to be reordered or re-received by the facility, but yet it comes. When at the same time, simple things like the folic iron will not be brought in because perhaps the resources were not enough, while the items that have taken resources are actually being redistributed and even expiring within the facilities in the district. Next. So as I was talking, I've been trying to also provide for what we need to do. However, this is a dedicated slide to answer, to try to answer what do we have to do to perform better. In one bullet point, we need to address the current supply chain challenges in totality. There's a say in supply chain that the weakest link of a supply chain is the problem. Even if it is one node out of a billion, that is already a broken supply chain. So, in terms of human resources, I'm glad Sister is talked about what Kabale wants to do. I don't know whether this is also true for all the other 134 districts. But moving forward, and as a supply chain activity, we plan to work with the Minister of Health, Minister of Local Government, Minister of Public Service, and Minister of Finance to develop a plan of how we should be able to deal with this chronic problem related to human resources. Alongside with these ministries, we shall be also working with the Uganda Health System Strengthening activity that is already on the ground, which deals with governance issues and others, to get this addressed in more of a longer term perspective. However, following on the footsteps of what Sister said, we are talking about short term, where we identify already there are gaps. For example, in every health sub-district, there is the position of a pharmacy technician, but many districts do not even go ahead to recruit this person. In every hospital, there is a position of a pharmacist and a number of pharmacy technicians, but many districts, majority of the districts, have never bothered to recruit this cadre. And in the medium term, continue to dialogue with public service, Minister of Health, and local government to ensure that first, if need be, restructuring is done to be able to think about more numbers, and definitely deploying of health staff in there for appropriate responsibilities. We also plan to work with the Minister of Health, National Medical Stores, and Finance, and of course the other partners, to try to look at how best do we address commodity financing. As you may have heard, every project now is talking about genital self-reliance, and this is
Martin, you can prepare to complete in the next 2 to 3 minutes.
This is my last slide. As you might notice, all the partners now are talking about genital self-reliance, saying the government should be preparing to take over financing for everything in the health sector in the long, not really in the long future. 10, 15 years is not very far from now. And so what we are working on is we are already working through the interministerial subcommittee to try to develop a 10-year roadmap where we are going to look at how financing for commodities, including, of course, ANC, maternal child health, altogether commodities, will be financed. So we shall be helping in identifying the gaps and looking at what strategies will be required to be able to achieve that. The other bit is we need to optimize and build on investments that are already made. A number of projects are investing on supply chain. They have done a tremendous work, but as soon as they leave, the districts also let go of these investments. And yet, These are for the benefits of the final person who is the mother who is in need. We need to be able to sustain this. We need to work towards a well-managed, equity-based allocation of available and future financing for health commodities, avoiding waste in the first instance before we look for more. We need to have, as I said earlier, a high level of efficiency. And this means working together as one, minimizing resource wastage, and doing so in due time. We need to use the logistic management information systems to generate the supply chain data and use that data to plan and take any other actions that we might need, including advocacy for additional resources. And finally, we need gradually to address existing supply chain infrastructure gaps along the supply chain. Over to you. I'm ready. I'm available.
Yeah, thank you, Martin, for the presentation. The slides were few, but it was comprehensive. It really tackled a number of aspects. And I think the most critical thing we need to know is that supplies and logistics are an important aspect of the effective antenatal care service. Sister was talking about availability of syphilis and HIV testing kits, essential medicines and equipment. That's a critical aspect for antenatal care services. And definitely the shortage of any of those supplies, drugs or basic equipment can compromise the quality of care, the motivation of staff, and also the utilization of the services. And the other key thing that you have emphasized is the need to be more efficient, more equitable. We need to plan better, but also we need to prioritize well the resources that we have such that we are able to fit within. But also it is important for us to pay attention to the quality of procurement planning. I definitely now have looked at some of the comments. Many of the comments are related to planning. Someone has highlighted the comment that we have seen that in many of the district procurement plannings, we hardly get midwives involved, and which is true in a number of districts. So members, this is over to you. It is an opportunity for you to raise your questions. You can put your hand up or you can put the question in the chat and Martin will respond. Questions, comments? And most of the issues in the comment section, someone is saying that they think data capturing regarding medicine stockout should be at the center of every health facility mission, but also the fact that someone has never seen midwives, especially from the health facilities, getting involved in the quantification process when the exercise happens at the end of the year is an issue of concern. So members, if you have any comments or any questions, you can raise them beyond those I've seen in the chat. Is there a hand? I know the topic on supply chain is always a controversial one, but it's also something that touches us because we know without commodities, there is no program. There is no treatment without the products at the health facilities. How do you ensure that we have a sustainable flow of commodities at the health facilities to ensure service quality, to ensure that the services are available to the beneficiaries in the quantity and the quality that is desired? Yeah, the slides will be shared. I've seen the comment, the slides will be shared. And another comment is that Finance Ministry, together with the public service, they really have to pay attention to the HRH components. Martin, there is a question.
Yes.
What do you recommend to manage supplies for quality antenatal care services? I think maybe from the past, at the level of the health facility, whom should you recommend to be the one managing the quality of, commodities to improve the quality of ANC services?
Moses, we have a big challenge, certainly. Of course, even when we talk about potential for expansion, which already, as you know, the UHSS is already setting the basis for, it may be very difficult for us to succeed in convincing the government to really put in 100% the foot soldiers. And in that respect, therefore, I rather have an extra hand, if it is in an antenatal care or maternal child health, an extra hand that ultimately, although focused at helping within the supply chain of that particular area in the ANC, maternal child health care, but also can do the other technical bits, maybe an enrolled nurse or what do you call them, these comprehensive nurses, and then be properly drilled to just support that maternal child health team with probably 70% of his or her responsibility, helping them in the planning, working with the in charge, because in Health Center 3, we don't have even a dispenser, unless that is going to be proposed. And then that fellow coordinates with the health sub-district, which is the Health Center 4, where there will be a pharmacy technician who will help them with the technical details. Of course, and then that particular pharmacy technician continues to coordinate with the district level, where then they are going to be possibly able to meet, to get better qualified people, ultimately supporting them, whether through some projects or, as we're already proposing, to have the DHT kind of, the government consider expansion of the DHT to include a pharmacist in the district to support the district health services. That is, for now, the thought. But in the interim, for some of you who might have interfaced with the medicine management supervisors, you know what they are able to do. And many of them are actually nurses and lab technicians and clinical officers. They can do a wonderful job. But of course, without freeing them from their core function, we will only be breaking them down and creating some of the system challenges that we now experience, bad attitudes and so on and so on, because somebody is overstressed.
Thank you, Martin. Thank you, Martin, for the response. Members, if you have any other questions, you can put them in the chat. Martin will respond. At this point, we are going to launch into our third session for the day, third presentation on HMIS data management, looking at the quality and utilization in antenatal care. And Dr. Wandera, who is the health analyst for USAID Strategic Information Technical Support Sites, is going to take us through this last session. You're welcome, Dr. Wandera.
Thank you very much, Dr. Walakira, and good afternoon, everyone. I'm briefly going to give you my take on really data management, quality and utilization for improving ANC services. And this is the process we shall go through. Really, I will just highlight why we need to care about data and ANC, and then because I'll provide some highlights of how we are performing in different areas of ANC, I'll provide the data source and some performance on that data, and also highlight some suggestions, practical suggestions on how we could improve data quality and utilization at various levels of our support within the health system. Of course, we all know that HMIS is the cornerstone of routine monitoring, and it is in this system where lots of ANC inputs, processes, and outputs are reported. And of course, it's not the only source of understanding or knowing how ANC performance is, but it is by and large the largest we have. And the other data sources, either through surveys, through different modalities that are really outside the scope of this meeting. I will also not try to really give you the structure, organization of the HMIS, nor provide really health system related indicators within the HMIS, but I'll limit some to really the practical day-to-day indicators that we interact with in the HMIS, limit them to FY20, and I will avoid tagging them to really how they are scored in the district league table. And of course, we know data in the HMIS enables us track performance. We use it to learn where we are doing well and where we need improvement. And also we use it to attribute particular QI processes or particular innovations and really account for any improvements that could be due to our pivot in implementation. And we can also use it to identify any weaknesses or barriers in the care that we are providing as we struggle to improve maternal and perinatal well-being. This slide really just highlights some of the various tools based on our role really in ANC care and support we've interacted with where different data for ANC is recorded and reported. And for the majority of the presentation, I'm going to use data from the National Health Management Information System that is recorded at each health facility, summarized and reported monthly through HMIS 105 to an electronic system called the DHIS2. And the data we're going to use really is data from January to June 2020 to highlight some of the performance and other data quality challenges. And this data was downloaded recently, and we conducted some really basic cleaning and removing really data inconsistencies, which is one of the features that we see in most of the data that we interact with. And this slide really is highlighting really the reporting rates and the sections of this reporting tool, the HMIS 105, where ANC data is reported. And we see that general reporting is very high in the upper 90s, although the lower line is showing that the reporting does not come in timely, as it is not received within the system by the 15th of the subsequent month. But we fortunately see this is improving along the way. And we probably have an idea why March was the lowest, because that was really at the outset of the response to COVID, that some of the officers responsible for reporting probably were not able to access facilities and conduct the reporting. But of course, we are very fortunate with the continuity of essential services. All these issues were factored in, and we see that reporting on data that is relevant for ANC has continued to improve, except the issue of timeliness. Regarding the regional variations, I gave a disclaimer. I'll try to not go into the district really and facility level details, but it is clear for all the 6 months of observation that the Kampala region, the North Central region and South Central region, which are really regions in Buganda, have generally lower reporting rates than the other areas. And when you further dissect this data, you see that these regions also have a higher proportion of private for-profit facilities that have registered through their districts to provide the reporting on ANC data, but some tend to lag in that role of reporting, and also reporting later rather than mandated. So this slide here is showing that there are two graphs here. The first one really is a very busy slide showing numbers and colors, but it's giving us really mothers who are attending antenatal care by the visit type. The first column really is the ANC first contact. The second is the fourth visit, and then whether the first visit occurs within the first trimester, and then what proportion of mothers attending antenatal care attend what we're now moving to 8 contacts. We see very clearly that ANC1, we are doing very well. This has been known for quite some time, and UDHS showed that we are really doing very well on that, although we see some some few regions that have some reds. Down there in the right bottom is the key we use to group those regional performances. We see as you move from left towards right, really the performance starts waning. ANC1 is excellent. ANC4, we see we start dropping into the 40s, and some regions of Bunyoro, Busoga, Kampala in the 30s. While ANC1 attendance within the first trimester is also very low as compared to the target. Right here, I give the targets for each of these indicators. But most importantly, generally, ANC1 is good. We know that. ANC4, we are moving, but still way below the HSDP target of 69%. We are in the 40s, and of course, the ball is in our court to make the first contact as fruitful and as interactive and useful for the mother to ensure that they're able to come back on subsequent visits. About ANC8, we see all regions really still have a lot of work to do, and really this data is also summarized here. We see that as the number of visits increase, really we see massive drops in attendance of these visits. And this slide tries to outline some of the districts that had excellent performance, and those with the lowest performance, excuse that spelling, on ANC4. We see a number of districts in West Nile, Kigezi, and Ankole among the districts with the highest ANC4 performance if you looked at the first 6 months of FY20. While we see a number of districts in Bunyoro, Busoga, and central, both north and south central regions of Buganda that are in the lower 20s. And if you remember the target in the HSDP and Chapin plan is 69%. So of course, attendance of antenatal care in and of itself is not all that is required there. Those interactive or useful visits that or services that are provided to the pregnant woman as they prepare for safe delivery and health of the mother and the baby. So some of the nutritional services that are targeted in the ANC are shown here using still data from the HMIS from January to June. And we see generally that we data on nutritional counseling for both maternal nutritional counseling and infant feeding. We tend to have mothers, way more mothers receiving that counseling than the mothers who attend antenatal care for any visit. So of course we try to work through and see where the errors could be, but it is very clear that for this period, we had about 1.72 million ANC visits, but we had about 2.1 mothers counseled, and where these others come from, really maternal nutrition counseling, that's really indicates some data quality challenges. And as you dig deeper, we're able to see that different regions are at different levels in terms of really providing data that can be useful to understand to what extent we are providing nutritional counseling.
Bonnie, Richard. Richard?
Yes.
Is it my connection or it's Bonnie?
No, think it's Bonnie. We are losing him. Let me reach out. I think he has dropped. He must be having connection problem. Let's give him a minute and see whether he gets back.
Okay. And I think as we are waiting for him, what I seem to be picking is the fact that along the continuum, we are seeing a significant drop and leakages. Very high ANC1. Of course, the attendance within the first trimester is very low, but also fourth ANC is very low, and it is worse with the new concept of 8 antenatal contacts model. So that's a big challenge. So probably the 8 antenatal care contacts model is not yet well adopted and operationalized. That could be a gap, but we're also seeing gaps. Yes, Bon, are you back?
Yes, I am back. Sorry, it's raining here at office, and probably that's why we're having these challenges. But thank you very much for covering that, Dr. Walakira. And we see really ANC1 attendance doing very well. But
just upload the presentation, upload.
Oh, okay.
We don't have it yet.
Okay. Is the screen reaching?
Yeah, we have it.
Yes. So I was saying that about half of pregnant women received nutritional assessment, and these were higher in the regions of Kigezi and Ankole, but Kampala and the regions in Buganda were really in the lower 20s. And I talked about the data quality regarding nutritional counseling. And we see really iron and folate supplementation is suboptimal, but it was clear that it was highest in Kigezi and Karamoja regions, but still lowest in the regions in Buganda. So this slide really is still highlighting that this is the only slide I will take you out of the HMIS. These are really maps from the most recent most recent UDHS, which is 2016. And we see still that if you look at iron and folic acid supplementation, which is the map on your right in green, we see Kigezi is reporting about 40% of the women that were, of the mothers that were interviewed, and Karamoja at 36, which I would say is not very different from what we are still seeing in the HMIs. These regions still had the highest proportion of pregnant women in ANC receiving iron and folic acid supplementation. And the map on the right is really, quote unquote, really reconfirming that the higher the iron and folic acid supplementation, we see the lower is the prevalence of anemia among women. You see Kigezi has one of the lowest at 16.9. And so just, I guess, to re-emphasize the role of iron and folate supplementation, which all of us are really converted, but just to highlight that it is very clear from data that the better we improve our ANC services, the likely for these results to even be evident in different data sources. So this slide is showing us the maternal and fetal assessments in ANC. And what is clear as you move from your left to your right, as the number of services increase, we see that there are drops along the way. So if there is any message I can give you is, as we continue to see mothers in care, we seem to be giving them less and less services along really the of those that are mandated to be provided in ANC. For example, the total number of mothers who attended ANC is about 970 for the 6 months that whose data we are using, and about 88% of them nationally received an HIV test. 83% received received an HIV test at any visit, while 83% received it in the first ANC, which is excellent performance. and we see still 83% received syphilis testing during the ANC. But when you go to the partners who are tested for syphilis, of course, this is clouded within the partners that were able to come to ANC. This drops very low to about 23%, while the number of pregnant women who receive an HB tests are really just at a dismal 14%. When you go to ultrasound, I know in the first meeting of our ANC series, there was a lot of discussion on ultrasound, its usefulness, and so we see at only 13%. And when you go to hepatitis B, as Sister from Kabale has also presented, this is really low, and these are national figures. This is at 8%. But I guess it is very clear that what HIV has been able to do with testing mothers for HIV and syphilis means these other services can also be scaled up to reach those high performances. So really, these are the regional variations in most of those performances, and they are not based on target, but just to emphasize that the green colors represent better performance as you move towards red, representing the lowest performance within each of the regions. And we see, like the other one, nationally, we see these regional variations, but just if I'm to pick out ultrasound, we see Kampala, about 42% of pregnant women attending ANC1 receive an ultrasound, then followed by districts in the central region. But as you move away from the center, really the proportion of women receiving an obstetric ultrasound goes down markedly, which is an average of 13% nationally. But we see Acholi at really 4% and Teso at 5%. So areas that really we need to work with different stakeholders to see what can be provided within the means, the funding basket that we have access to. The other results can also be seen within the same context, the various regional variations, including for Hep B. So regarding services for assessment, treatment, and prevention of anemia within ANC, still I begin with the total number of women that we saw nationally within the period of January to June.
Bonnie,
yes.
Bonnie, you can plan to summarize in the next 5 minutes, such that we have some 10 minutes for the discussion.
Oh, okay. So I guess here what is clear is that the number of women that are receiving services, folic acid, iron and folate, and then tested, and then keeps falling along the cascade of care, and still regional variations in those services. So this slide is really a deep dive on ultrasound scan. I already highlighted the regional variation, but on the right, we see the variability in ultrasound scanning by health facility ownership. Down here, we have government, the private not-for-profits, and the private for-profits on the extreme right. And we see the higher the health facility level, of course, to some extent, the pregnant women were receiving an ultrasound, and lower facilities still need a lot of support. And we see that private for-profits are really doing way better than the PNFPs and the government. And so, and this is mirrored across the whole, across the different regions. Regarding ANC prevention interventions, I think we're doing well regarding IPT1, which are the dark blue bars. We are in the 80s, but IPT-P3, with the national average is 47%, which is way below the target. And the Kampala is even doing way worse than the other regions. But we see West Nile is doing very well in LLIN, West Nile and Lango. And we also see really a high IPT-P3 in Acholi, and they might have some lessons to share during the Q&A. So regarding really anti-helminths, generally there's still room for improvement across most of the regions. but Kampala seems to be generally lower than all the other regions. And still, this really shows the proportion of women who received a blood grouping still can be improved further. And I can, since you've given, I think there is a role of really, if we're talking about the processes of improving ANC data quality, really it's our role as facility data managers, as health workers, and we should not be leaving it to really records assistants and health information assistants. So at each of our various levels, we have a role to play, from health facility, rather clinician, records assistant, and then as you move across the chain of really health management up to the national level, as I highlight there. So we should not be looking at it as work of the M&E teams. And then, this slide really highlights some of those ways we know districts and IPs have supported training of trainers and providing last mile training on the revised HMIS tools, really continuous recording and documentation, and improving SOPs for data collection. Of course, working with facilities to improving tool quantification and ordering. And we know some IPs support printing, but there's really an announcement here that it's always good to liaise with the DHI before supporting printing to ensure geographical equity, and then as well as further account for version controls, because some of the tools get revised over time. And of course, we have to continue advocating for addition of other data entry checks to improve the data that is being entered into the electronic HMIS system. We have to work through data quality review meetings and across the different levels to really conduct data quality reviews. And as IPs, as districts, all these efforts should really be focused to areas where there is most need, rather than doing them as routine, but we should target to areas that are most in need, and we should always not forget involving the private for-profit facilities, because they contribute a lot to the national outputs. And so other ways to improve the data quality, designing CQI projects along really the continuum of data collection and reporting. Also, we need to work to improve data utilization by institutionalizing it through routine data utilization activities. And of course, Sister talked about performance review meetings. And now with the coming on board of RBF, really we use that avenue before submission to ensure that probably a commensurate compensation is done by using that opportunity to review the data before it is submitted within the HMIS. And one of the big avenues we can increase utilizing the beautiful, the magical, the lots of data for ANCs through utilizing the RMNCH scorecard, which is a tool to enable facilities and districts improve service delivery. And previous in the, I think the previous MCH at TWG, it was showcased as a tool to really support performance management and ensure accountability across the continuum of RMNCH services, of which NC is part of, and uses really the usual red, yellow, green colors to highlight indicators that are doing well and where support is needed, and involves active dialogue and understanding data at its source or at a district level. And there are processes that need to be followed to utilize data at the scorecard, and how this then is used to plow back into improving the performance of ANC specifically. The Secretariat will share slides, and these steps are really highlighted here. And why I like the role of using really the scorecard, because it also involves some of the key ANC indicators which I have circled there. really this, it is more comprehensive, but some of the ANC indicators are really highlighted in there, and really this is the leveraging on already existing systems to improve data use. So the HMIS provides us an opportunity to review and monitor our ANC performance, and there's data collected and reported, which we need to use routinely to improve ANC programming. I've highlighted how ANC attendance, ANC1 attendance we are doing very well, and we need to really now the issue of the quality of this visit and how we can utilize improving the quality of that visit to ensure that mothers are able to come back on subsequent visits. We still have a lot of effort to improve on ANC4, and even more effort for ANC8, and including the improving really early ANC attendance to be able to have enough time to attend a number of ANC visits. Of course, I highlighted some data quality issues, and that could be improved further. And I talked about really a lot of effort still needed to improve ultrasound access and even timing. I might have not talked about the timing, but it's clear in there that those who receive an ultrasound within the 24 weeks was even lower than the 13%. And then I highlighted really malaria preventive interventions and other ANC interventions, and where we are and where different regions are. And of course, routine HMIS data collection, reporting, and review is really not dedicated to the HIAs or the records officers for those higher level facilities that have them, but it requires input from all of us as clinicians, as midwives, and really, and also organizing, attending, and conducting data review meetings to utilize that data. So thank you very much, everyone. And I want to thank really different stakeholders at various levels, and funding from USAID to allow us provide this kind of support, and most importantly to the people of Uganda who are support. Thank you very much, and over to you, Dr. Walakira.
Yeah, thank you so much, Dr. Wandera. It has really been a comprehensive presentation, but most importantly, we do practical steps regarding what we can do, especially to improve the quality of the data, but also to improve the utilization as well. You've clearly highlighted that HMIS is the cornerstone for health facility monitoring, and the presentation has clearly indicated that we have a lot of gaps, leakages along the continuum, especially when it comes to continuous utilization of ANC services. We have also seen that the 8 ANC contracts model is not yet fully operationalized. We have seen major gaps with uptake of certain services in ANC, the ferrous and the folate, and the nutritional service, nutritional assessments is also a major gap. You've clearly highlighted the fact that IPT3 and the early line coverage is a challenge for most of the regions in the country, and I think we need to focus on this, but also you highlighted the importance of institutionalizing data use to improve performance. Maybe we shall have in the subsequent webinars, we shall have a discussion on the RMNCH scorecard. I think the Secretariat will discuss that, and we really give it some time for members to appreciate it. Thank you so much. This is now open to the floor for any questions. To Dr. Wandera, any questions I've seen from the comments section, but also thank you, Martin, for the responses. I've seen you've given comprehensive responses for the questions that team members have raised through the chat. That's very impressive. Some of the members have been raising comments, just comments that there is a need to strengthen support supervision, visits and mentorship, and mainly on the MCH indicators and the quality of care. And members are also emphasizing the need to improve record keeping. And sometimes you might find the low uptakes because of the gaps in documentation. Any hands? We have about a maximum of 8 to 10 minutes to conclude our session. Okay, I've seen. Willie?
Thank you very much, Dr. Boni, Dr. Moses. It was an excellent presentation. My concern was on the 83% achievement. John to John, should we assume that it was an effect of COVID? Because we've been celebrating that as far as first ANC testing is concerned, we are in 90s, but now if we look at half a year, we're at 83%. Can we attribute that to COVID or something? Then also, secondly, I wanted to find out from Dr. Boni if he looked at the partner testing, those identified positive, and then the treatment for the closing of the rope as far as that cascade is concerned. And eventually, I loved the way that you teased out the PNFPs or Center of Excellences in terms, the PNFPs in terms of their scan and so on, so that they're not, these other facilities are not, the graph comes out very well. And maybe we would also do a model to find out if we have any loss somewhere in terms of the first ANC, looking at our population, media population, and versus our achievement. Where is the PMTCT start, or where is the first ANC? Where are we losing the mothers, focusing on either looking at our coverage, and then we go through from the population and until where we are versus the achievement. But thank you very much. I loved the analysis, and I loved the science behind. Thanks.
Yes, Stella.
Thank you very much. I have a concern or two. First and foremost, it came out clearly in one of the graphs that the 8 contacts, it seems the concept is not well embraced. And maybe most of the midwives don't know what is the package at every contact. And my concern is, what can be done about this? Because it is evident that we are not doing very well as far as 8 contacts are concerned. And secondly, I've also observed that in both Sister Immaculate and Dr. Boni's presentations, the HB estimation is very low. And we know that HB estimation in pregnancy is something that is very paramount we improve on.
So Stella, it seems we have lost you. When it comes to responses, I would request Dr. Oliver, I've seen her, she's on the call. She will talk about the 8 contacts, ANC contacts. Dr. Myers Rugemwa.
Thank you very much. I think data is power. What Boni has presented on the poor statistics in ANC attendance in Bunyoro, Central, and Busoga should raise an eye to not only the implementing partners, but I think to us at the ministry. It's of great concern. Even coming further to the ANC ultrasonography of 13% is another concern, which does not meet the new WHO Ministry of Health guidelines. And also coming to IPTP3 in Kampala, which is at 13%. it's quite, it's painful. It's very, very painful. So I think these are issues that should not only end on at this webinar meeting, but I think they should be brought forth to the ministry at the senior management meeting, so they are even recommended further for address. Otherwise, we cannot continue into that scenario. Trying to answer, I think this was Abigail's concern, that the scenario of, although you asked Olive to respond, I believe she will add on, the new WHO guidelines on ANC and Marian pregnancy, and this is as recently as 2019, which the ministry has adopted and adapted to fit into the scenario. 8 contacts is what, by the way, used to be the previous contacts in the old medical school. The 4 contacts have just been, they are the ones which came in on board. But 8 contacts, we need to train, and actually the trainings are ongoing. Maybe in the next 2 weeks, we shall be training the midwives and all people dealing with the obstetrical management, especially the midwives in the southwestern region. The trainings have been ongoing, and I think I would like to ask you to, I think this was Abigail, to look out for that training in case she has not been trained over the reason why there are 8 contacts, why we should have IPTP3+ and the staff. So I think, Abigail, look forward to that reason, but the guidelines now currently talk of 8 contacts, not even visits, and we're talking of a package. So we're no longer calling them visits, but we're calling them contacts, because the contact is more to the patient, to the pregnant mother, than the other visits. It's not just like you're going to visiting the park. There's a lot more in that package than has been the odd case. Over, Mr. Chairman.
Yeah, thank you so much, Dr. Myers. Dr. Sentungwe.
I think, thank you very much, Chair. Thank you very much, colleagues who have presented. And Myers, of course, as he's saying, the 8 contacts now, the word contact, as he has said, has been used to ensure that we are addressing the real care, the medical care, which we need to be giving to women when they come for ANC, as laid down in the ANC protocol. What do I do in terms of health promotion, in terms of lab investigations, in terms of examination? First contact. First contact is being made between the 8 to 12 week. That's in the first trimester. Then you want to look at 2 contacts in the second trimester. Anywhere between 24 to 26 weeks. Contact 1 can be made at 20 weeks. Contact 3 can be made at 26 weeks. We are spreading out these contacts. And you can see that most of the contacts are being made actually in the last trimester. Why? Because that's where we are picking for both mother and child very, very critically, to ensure that all the things which normally occur in the last trimester are correctly studied by the health worker, and the mother and the husband are able to discuss management during the actual process of delivery, but also if it requires urgent attention, they can be admitted to the health facility before major complications which cannot be dealt with occur. So there are 5 contacts in that third trimester at 30, 34 weeks, 36 weeks, 38 weeks, and 40 weeks. And hopefully that by 40 weeks, everybody would have delivered. And if not delivered, the health worker must make emphasis to inform the mom that at 41 weeks, they must certainly return for further assessment to ensure that things do not go wrong. So
Okay,
thank you
so much.
Myers. Contact is actually a medical contact, no longer a visit where we do just give an antenatal card and wish them well with the 10 tablets of iron and folic acid.
Like we are
Yeah,
visiting a nightclub.
Thank you so much, Dr. Sentumbe, for clarifying a number of those issues. Bonnie, in just a minute, you can respond to some of the comments and we conclude. We're ready for time.
Yes, thank you very much, Dr. Walakira, and thank you for your questions. Yes, Willie, I think really the part of the reduction in really HIV and syphilis testing to slightly lower numbers. I don't want to say it is all due to COVID per se, but I know the calculation for this indicator for really the HIV program is slightly different. Here, we are looking at those who received the testing at NC1. So when we drill down, we can be able to tease out which areas are still lagging, but we also know that the effect of COVID was really limited mainly in April and March. So I don't want to say it is due to COVID. And the other issue of really because of time, I want us to just to mull over or to go thinking what would happen if as a facility or as a district, we review our data and we see that one of our needs is really an ultrasonographer. Probably we have an ultrasound machine at our district hospital and it's not being utilized fully. And how are we tapping into the RBF funds to support this? So it's just food for thought to really, as a response to the contributor who was concerned about really the low level utilization of ultrasound and the low ANC contacts. So I think we have to think harder how we're utilizing RBF funds and see how we can innovatively do that. So apart from that, I think the other really comments and Oliver and Myers have ably answered most of them.
Yeah, so thank you, Dr. Wandera, for the presentation. It has been rich and very resourceful. I hope the members have appreciated your presentation. And I would like to thank the three presenters for today, Sister Immaculate, Martin, and Bonnie. It has been good work, good presentations. I think a lot of work went into the preparation of the presentations. There have been quality presentations. Members today who have appreciated the role of leadership and governance in improving the ANC coverage and the quality demonstrated at a decentralized level. We have gone through the role of supply chain and we have appreciated that this is very key in improving the quality of mental care, but also it is key in terms of motivating the staff, even the clients to come and utilize our services. And lastly, we have seen that data is power and we need to continue focusing on institutionalizing data use. Thank you so much. And I'm Dr. Walakira Moses, who has been your moderator for today. Over to you, Richard.
Thank you so much, Dr. Moses Walakira. Thank you for moderating this session. Thank you so much, wonderful speakers who have done a great job. And Martin for taking off time from your vacation to be with us as well. Thank you, members, for participating. I just want to highlight the next webinar. Our next webinar is next Monday, same time at 2 p.m. And our topic will be around current practice and management of common antenatal care conditions. For example, management of hypertension, of syphilis, of malaria, nausea. So we'll have a very wonderful panel of clinical experts to take us through the current protocols and management of some of these ANC conditions. So please join us. Get as many health workers to also join in and be updated. I will be sending out emails and WhatsApp reminders. You can always use the same link if you registered for all the webinars, or you can register again for next Monday's webinar. Thank you very much and have a good evening.
Thank you very much for the presentations and the organization, Dr. Waswa.
Yeah. Thank you and bye.
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 Thank you for the organization. It has
You're
been very
welcome.
wonderful, very educative.
You're
Have
welcome,
a nice.
Christine.
Thank you,
Yeah.
Christine.
Thank you.
Thank you all.